It's recording.
Okay. All right. So it's just afternoon. So we're going to get going. Today we have Dr. Valerie Harder, who's an associate professor in the Department of Pediatrics and Psychiatry at UVM at the College of Medicine. Dr. Harder is an epidemiologist and has a master's in biostatistics. She is Director of Health Services Research for the Vermont Child Health Improvement Program, or VCHIP. She focuses her research on measuring the impact of public health interventions to improve physical and mental health outcomes of youth and young adults statewide. Her research team leverages large administrative health data sources, and she leads evaluations of health systems in primary and specialty care. Today, Dr. Harder will share her work as co-lead of the Surveillance and Evaluation Core of the Center on Rural Health. And I'd just like to say you can save your questions for the end, or if you have a real burning question, feel free to interrupt. All right, thank you.
Thanks, Kirsten. Hi, everybody. Hear me okay? Thanks for that nice introduction. I'll get started here. The talk today is called Concerns and Beliefs about Substance Use and Treatment Among Northern New England Practitioners. And as was mentioned in the introduction, I co-lead the Surveillance and Evaluation Core for the University of Vermont Center on Rural Addiction, or Quora. And the UVM Center on Rural Addiction is a new center at Vermont, and I'll tell you about it at the first part of this talk. After that overview, I'll talk about baseline needs assessment that we've been conducting in Vermont and New Hampshire, and we're expanding to Maine and Northern New York soon. I'll go through the results of our baseline needs assessment that we conducted, and I'll share topics related to concerns about substance use as reported by practitioners that are working across Vermont and New Hampshire, as well as results related to their comfort in treating patients with substance use disorders, and specifically about opioid use disorders. And then I'll show you some results about their beliefs. We asked some very specific pointed questions about their beliefs around treatment of substance use disorders. And finally, I'll end with going through a study, a manuscript that we've submitted to a journal is under review on the associations between comfort treating opioid use disorder and barriers to treatment that practitioners shared with us in the baseline needs assessment. So briefly, a little bit about Quora. The mission of Quora is to expand addiction treatment capacity in rural communities by providing evidence-based technical assistance, consultation, resources, and education to healthcare providers and other staff. Quora has 4 cores within the center. The first is the Surveillance and Evaluation Core, which I co-lead with Dr. Andrea Bellanti. We conducted this baseline needs assessment. We're also assisting providers and practices within some technical assistance to improve data collection. And we're also looking more broadly at monitoring drug use patterns in rural communities and collecting data and sharing our summaries. There's a best practices core, which gives technical assistance to help practices and practitioners implement evidence-based practices. There's a clinical advisory board. Many clinicians who have been working with patients with substance use disorders across Northern New England for many years, and they help guide our work and provide their expertise. And we have an outreach and education core, which does a lot of presentations and helps educate and gives these community rounds, they call it. Here's some nice pictures and information about the different faculty and staff members in Quora, as well as our clinician advisory board in Quora. And our partners, we have partners in Maine and New Hampshire and Northern New York, who have worked closely with us over the last year and a half for us to build this Center on Rural Addiction and to help extend the sharing of evidence-based practices across practitioners in all of our states. There are many ways to connect with Quora. They're listed here. You can send an email to Quora at UVM if you want any more information about our work. We're happy to talk with you and help you get involved. At this point, I wanted to thank Nate Shaffrick and Julia Shaw and Caitlin McCluskey. They're members of the Surveillance and Evaluation Corps, and they helped me prepare the data that I'll be showing you today. So thanks a lot to them. Now I'll move on to give you an overview of our baseline needs assessment. The Surveillance and Evaluation Corps, as I mentioned, conducted a baseline needs assessment in Vermont and New Hampshire. We're moving into Maine and Northern New York. And this assessment was to examine mechanisms to improve the delivery of evidence-based substance use treatment and training for providers in rural Vermont and New Hampshire. The survey in Vermont was rolled out between April and August of 2020, and it was during the COVID-19 pandemic, and it was an online survey, and we had gotten everything ready in February to start it, and in March it got delayed, and then got delayed even more because of COVID and everyone went home for work, but we were able to launch it, and we had 2 waves where we collected rural practitioners, those who worked in primarily rural areas of the state of Vermont, and then more metropolitan areas in Chittenden County and surrounding areas we call non-rural, and we'll talk about that. In New Hampshire, we launched a survey at the second half of 2020, beginning in October, and extended it into March 2021 to collect data. As I mentioned, these were electronic surveys, and we gave an incentive to the practitioners to complete these surveys. So in Vermont, we had given the survey out to 1,462 practitioners, and these are practitioners in clinical roles, and I'll give a little bit more description of who they were in a bit. And 332 completed our online survey. We had started from a list of practitioners that were licensed in Vermont. So we had that information in Vermont, and then we narrowed it down to a targeted set based on the taxonomy of the practitioner, of those who were likely to provide treatment to patients with substance use disorders. And it was quite broad. A lot of the work of Quora is focused on primary care. So we made sure to include all of those taxonomies of practitioners. In New Hampshire, we had 246 practitioners in clinical and counseling roles that were sent the survey to complete, and 152 completed that with the same incentives that were given in Vermont. The surveys were administered a little bit differently. We didn't have as many, we didn't have the long list of everyone licensed and their contact information in New Hampshire. So what we did was we first initiated a contact survey, like a general broad email that went out to people that said, if you're interested, click on this, share your information, then we'll send you the survey. And that was our way of validating that they weren't an online bot that was just trying to get an incentive. So we had a smaller base who were given the real survey, and then it was a bigger completion because they were invested and said, yes, I'm interested as a first round. So in Vermont, I have in this image showing you the green shaded counties that were designated rural. And this is a health services, this is a HRSA designation for rural that we use. The gray shaded counties in the upper left are what we're designating non-rural. We're not saying they're urban, but they just weren't HRSA designated rural counties. So here you can see the Vermont counties listed and the frequency of participants from all these different counties that we had. Non-rural counties are at the bottom, and some people said they worked in multiple, and we would then include them if they had any rural or depending on how we were analyzing our results. Similarly for New Hampshire, there are majority rural counties, and then Coincidentally, there are 3 non-rural counties in New Hampshire as well, down closer to the Boston and Maine, Portland, Maine area. And here you can see the breakdown of the frequencies of participants in each of the rural and non-rural counties. You can see we had participants from all the counties across New Hampshire, out of the 152 that responded. As I mentioned, there were different roles of practitioners. We sent it to a broad base of different practitioners with their taxonomies from the list that we had. And what you can see in these pie charts is that there's different makeup of the roles in the 2 states that we've surveyed so far. In Vermont, the majority of the participants were primary care practitioners, and then followed by specialist physicians. So maybe a substance use or addiction psychiatrist would be a specialist that would fall into that category. We also had a large group of physician's assistants and not as many nurses, although we tried really hard to disseminate 2 groups of nurses that we knew about. In New Hampshire, it's much more varied, and the largest group of respondents were actually counselors or psychologists, and then advanced practice nurses, so those NPs that are out there that can prescribe and work in primary care and other locations. So that was a great thing that we got more nurses involved in our New Hampshire survey. And we also had primary care physicians. So just keep that in mind as you're looking at the results that I'm going to show you. There are some differences in the roles of the participants in these surveys between Vermont and New Hampshire. And then also there's distribution across rural areas and non-rural areas where people work in the 2 states. I forgot to mention at the beginning, if anyone has a question while I'm showing you these results, please put it in the chat, or maybe you can raise your hand and Jennifer or Kirsten or Jessica can let me know that someone has a question. I'm happy to stop and talk while I'm looking at the particular data slide, because I'm going to show you a lot of slides of data. So it might be a little bit too much. So if you have a question in the moment, go ahead and ask. The first image I'm showing you here is us asking practitioners about their concerns around substance use. These are the Vermont and the New Hampshire practitioners. So specifically, we asked them, how concerned are you about the use of the following substances among your patients or in your practice? So what you can see here, green, or the first bar on the left, is Vermont, and the yellow bars are the New Hampshire responses. And in Vermont, the highest concern was expressed about tobacco use among their patients, followed by alcohol, and then opioids and alcohol combined. And the concern was a scale of 0 to 10, 0 being no concern and 10 being extreme concern. So this was a continuous scale. And what you can also pick up from looking at this graph is that the practitioners in New Hampshire had higher levels of fentanyl, heroin, and particularly methamphetamine. And one thing that we've been thinking about is the time frame in which we surveyed these practitioners. We surveyed the Vermont practitioners at the beginning of 2020 and into the middle. And then by the end of 2020 is when we started the New Hampshire one. And even over this past year, there's been a lot increase in concern around methamphetamine. So that might be due to the different time periods. Maybe if we assess the Vermont practitioners again right now, they'll show greater concern around methamphetamine as well in the area. So this next set of data I'm showing you are practitioners' response to the question, how comfortable are you addressing treating opioid use disorder in your patients? So looking at the Vermont data on the left, we see that rural practitioners had slightly higher average comfort levels compared to non-rural practitioners in addressing or treating opioid use disorder in their patients. difference here is, although there's a lot of overlap in this box and whisker plot, it was statistically significant in the simple tests, as well as when we controlled for whether the practitioner had reported being waived to prescribe buprenorphine. And that's the medication used to treat opioid use disorders in an office-based setting. So if a practitioner, that could really influence their how comfortable they were in treating. So we controlled for that in a multiple regression model. And it was still a significant difference between a rural and a non-rural areas of Vermont for the practitioners. In New Hampshire, you don't see that. I mean, and also what you see is not only is there no difference in the level of comfort among the New Hampshire practitioners in rural versus non-rural, but overall their comfort levels seem to be a lot higher. They're up towards the top of the scale on that scale of 0 to 10 on how comfortable you are. And that is different visually from what you see in the Vermont practitioner responses. So this next slide is showing you the responses to the question, to what degree do you feel you have the training, experience, and supports you need to induct patients on opioid treatment medications? So that's that medications for opioid use disorder or buprenorphine that I was mentioning. So on the left, you see our response from the Vermont practitioners. And again, this is a self-rated experience on a scale from 0 to 10. And among the rural practitioners, they have a high, they feel that they do have the training and experience and support to induct patients. Well, interestingly, the non-rural practitioners have a lower response to that and are not feeling like they have as much training and experience to induct patients. In New Hampshire, the story is a little bit different, in which there really wasn't any difference, again, between the practitioners working in non-rural areas and in rural areas on their feelings of how much training and experience they have. And one thing I want to point out, this question was only asked to practitioners who can prescribe medications. So that's not a factor in looking at these associations. Just a reminder, while I was making this presentation, I thought, oh, maybe people might want to see the rural and non-rural areas again. So this is just for you to think about what areas in Vermont and New Hampshire are rural and which ones are non-rural. In this slide, I'm showing you Vermont practitioner comfort treating substance use disorders among special populations. So there's a lot on the slide that I want to talk about. And the practitioners were responding to the question, how comfortable do you feel providing the following services? And so the Vermont practitioners overall were most comfortable providing substance use disorder treatment to older adults than they were to pregnant patients, or providing family-based, or providing treatment to adolescents. But overall, you can see that their average comfort is on the lower side for these special populations, lower than overall their comfort treating, the general adult population for substance use disorders. And the only statistically significant difference on average level of comfort treating substance use disorder between the rural and the non-rural practitioners was for treating older adults. So this average score of 5.6 versus 4.3, that is a statistically significant difference between rural and non-rural, where the practitioners working in rural areas are feeling like they have higher levels of comfort treating older adults. And this was stayed significant even after controlling for whether or not the practitioner was waived to prescribe buprenorphine. So we have, as I mentioned, that statistically significant difference. We didn't find a statistically significant difference between the pregnant patients for rural and non-rural. nor did we find a difference between family-based in rural and non-rural. And in providing substance use disorder treatment for counseling for adolescents or minors, rural practitioners did report higher comfort levels than non-rural in simple analyses, but then the difference was not significant when we controlled for their ability to prescribe buprenorphine and having this waiver. So there's a couple of takeaways from here is that the comfort treating substance use disorders in these special populations is low across both rural and non-rural, and might even be a little bit lower in non-rural areas of Vermont. So now let's take a look at New Hampshire. So they were asked the same question, same categories of special populations. And overall, practitioners in New Hampshire reported higher comfort levels in treating special populations as compared to what Vermont practitioners. If you recall, the Vermont practitioner numbers were down near 5 and 4 and 3. And these are, older adults are up 7, almost to 7 and 6 for some of these groups. So just overall, they're reporting comfort level is higher. Again, thinking what we're going to dig into a little bit more are the different roles of the practitioners. Again, in New Hampshire, we had more counselors and psychologists and nurses responding. And in Vermont, we had more primary care providers and specialists responding. So there's definitely more to look into related to the role and not just the rural and non-rural comparisons. But what we did see similar to Vermont is that the rural practitioners had slightly higher levels of comfort that they reported in treating their patients for substance use disorders in these special populations than the practitioners in the non-rural counties. So it's a really interesting pattern that we see replicated across 2 states now. In this slide and this figure, I'm showing Vermont practitioner-related barriers to treating patients with opioid use disorder. So we asked them questions and asked them to identify their top 3 barriers that they felt as a practitioner to being able to treat patients with opioid use disorder. And again, we are showing you visually this breakdown between rural and non-rural. And now this graph is showing you percentages. So it's the percent of practitioners that identified each specific barrier that's listed along the bottom x-axis here in the figure. So the first barrier was that they said, well, I have barriers to time, and I have time and staffing constraints. And that's a major barrier to treating patients. So in Vermont, the biggest barriers that they had, regardless of rural, non-rural, were time staffing, medication diversion. They were worried about that, managing patients in their practice, and also their own training to be able to provide effective treatment for patients with opioid use disorder. So again, we ran some regression analyses and examined the association between the practitioner level initiating practitioner related barriers to initiating treatment. And we controlled for the rurality of the patient, adjusting for whether they reported currently treating patients for opioid use disorder. And these differences that you see visually here between rural and non-rural weren't statistically significant associations, although you see there's some differences visually. So it seems that it's more interesting from here to look at what were the biggest barriers, what should we focus on if we're hoping to alleviate those barriers to practitioners who are wanting and able to provide patients and treat them for their opioid use disorder. This is the same question and asking practitioners now in New Hampshire. And the figure shows, again, the rating of the top barriers and the percent of practitioners that rated that barrier as one of their top 3 barriers to treating patients. And similar to Vermont, in New Hampshire, practitioners identified time and staffing, training as major barriers to providing treatment for opioid use disorder. However, New Hampshire practitioners were also concerned about their organizational barriers, so some bigger topics or the bigger organization that they work within, and that being a barrier to them providing treatment, as well as stigma towards patients with opioid use disorder. We did some multivariable logistic regressions again on these, looking at the association between the practitioner's barriers to patient treatment initiation and practitioner rurality. And again, we found no significant differences in New Hampshire. Yeah, so again, rurality didn't seem to play a big role in the reporting of barriers, but there were some slightly different barriers between the two states.
Dr. Harder, we have a
Yes.
question here.
Sure.
Somebody was wondering what are some of the examples of the others that were listed, so other barriers?
Oh, I'll have to look those up. I'm sorry, I don't have those right off the tip of my tongue here. I might ask my colleague Nate, who is on, to maybe look those up while I'm continuing to talk, and at the end maybe he can share that with us. Oh, unless he knows off the top of
I can
his
look
head.
up what was listed. I would have to look up other text responses.
Okay, maybe he can look that up while I'm presenting, but that's a great question. Sorry, I don't have that right off the tip of my tongue there. Those are the Vermont ones. Those are the New Hampshire ones. Oh, no, these are patient. Okay, they look very similar. So in addition to practitioner related barriers, we also asked the practitioners to report on what they had observed and heard were patient related barriers. So we didn't ask the patients themselves in these surveys, but we asked the practitioner to report about the patient. So it's a secondhand report, but they do have a sense of some of the patient related barriers. So again, this is percent of practitioners reporting that these were patient related barriers. So in Vermont, again, time, but this is maybe more related to transport and other supports for the patient to attend the visits to receive treatment. And then the second highest related patient barrier was stigma of opioid use disorder. So this is coming up a little more, and we had some great presentations recently within the Center on Rural Addiction that talked more about stigma, and we're starting to work more and focus on that and work with practitioners around stigma for treating patients with opioid use disorder. Again, the differences here across rural and non-rural areas weren't evident, that there were different barriers. But again, it might be more elucidating if we actually talk to the patients to see what are their barriers based on where they live. So in New Hampshire, when the practitioners reported on the patient-related barriers, they too identified the same two as the highest barriers. I mean, the most frequently endorsed patient-related barriers were time and transportation and other supports to getting to treatment, as well as stigma related to opioid use disorder. When we did some of our regression analyses, we were looking at rural versus non-rural comparisons, and actually insurance or reimbursement came out to be potentially different in these two areas. So rural practitioners had 77% lower odds of identifying insurance as a patient-related barrier to treatment compared to non-rural practitioners. So that's something to think about a little bit more. We're doing some analyses around the rural or insurance and barriers that I'm going to talk about in the study in a few minutes. So there were here again no other statistically significant differences.
Dr. Harder, there is another question in regards to those results that you just shared from Kristen Sylvia, who asks, you may be getting to this, but do you have ideas about why there are significant differences between the two states? And I guess I might tack on to that. I wonder if you think the difference in the way that the surveys were sent out, like sort of the pre-selection in the New Hampshire population, if that might have contributed to some of the differences that you see.
Well, I mean, I'm showing some results where you do have differences between the states, and some results where, like this one about patient-related barriers, seem very consistent across the states. So in terms of the differences, I think it does play a lot into the roles of the practitioners who were responding. We have very different roles from those pie charts I showed you in the two different states. In terms of your question, Jessica, related to when they were rolled out and the time frame and the way that we did the surveys, and one was we had these long lists of all the licensed practitioners and we sent it to a mass of over 1,000. And in New Hampshire, we didn't have those contact lists. So we did, listservs of all the major organizations, professional organizations across Vermont that would blast it out to a lot of different people who might want to respond to the survey, and then they self-selected to say yes on a first click, and then we verified that they were practitioners in the state and sent it to them. So it was a more targeted. So both of them were, receiving an email, and seeing from one was more of a listserv email that might not have got enough attention. But I feel like we reached, we got it out to the same taxonomy of practitioners, but one way where we had the direct email to them and one where it was more listservs that they would have had to respond to, I think really affected who responded and who had maybe had time to open something or were more used to working in that and responding to a listserv. So we'll definitely have to think more about that. But I think it kind of comes down to the roles at the end of the day. Part of our survey also collected some qualitative responses. We had some open-ended questions. One of them was, is there anything you'd like to share with us? I mean, they've been answering all these questions and giving us their opinions. And here's a couple of quotes from a New Hampshire practitioner saying, our area is in need of mental health services and more on the ground OUD treatments. There's been a lot of efforts, policy efforts around treatment, improving treatment accessibility in the two states. Vermont had rollout of those services with hub and spoke much earlier than New Hampshire has. It seems that New Hampshire still wants that and needs that. And a Vermont practitioner said having a good MAT, which stands for medication assisted treatment, that's the prescription of buprenorphine in office settings. Having a team has been extremely helpful. Having more than one provider in the clinic that provides Suboxone is helpful. We're working hard to educate other local clinics at how easy and rewarding this care can be.
Valerie, this is Gary Stein. There are a couple of opportunities in terms of trying to increase engagement of practices. One is the Northern New England Practice-Based Research Network Co-op, which was the Dartmouth Co-op, and that has now been sort of restructured so it covers all of Vermont, New Hampshire, and Maine. And there is a focus, of course, on primary care practices with emphasis on rurality. So that's a group to be able to go in to engage additional practices in the areas that are predominantly rural. So that's one group. The second thing I was going to mention is that the principal responsibility of the Northern England Clinical Translational Research Network is health and healthcare challenges with a focus on rurality. And there is interest in the other CTRs. There are only 12 of them throughout the country. And so if there is an interest in expanding, that's a group that we could put you in contact with, and it may be a way to be able to look at similarities and differences, because one of the things that seems to be increasingly evident is that there is not a single definition of rurality. I mean, yes, I mean, there's the HRSA definition of rurality, that's largely population-based, but it would be informative to really look at where you have similarities and differences in these rural communities, and then relating that to healthcare and healthcare practices. So there would be some shared interest in that as well. So that's another group that we could go ahead and explore, interests in. And then
That's really helpful. I think that the more national scope is something we might be getting into. So Quora is looking ahead to the future years and thinking about expanding some of our assessments out more broadly nationally. So I think that connection would be really useful for us. Thank you for identifying that, reminding me about that, about our other CTR groups across the country.
Yeah, so that's a possibility. The
Yeah.
other thing with respect to, there's this hypothesis that investigation requires funding. And so there are opportunities emerging rapidly now for supplements to CTRs and to other funded programs as well. And rurality is an area that they are emphasizing. I mean, now suddenly rurality is a legitimate disparity. I mean, and so it becomes important. So we will definitely bring some of those to your attention as well. And now you've got all of these COVID-related complications, and COVID has not gone ahead and increased the ability to treat, and it certainly has not gone ahead and reduced some of the factors that lead to addiction. So again, there are some real opportunities there. We'll bring those to your attention.
Thank you so much. That would be wonderful. Have some more slides. I know it's a lot of data. I just thought I'd show you everything and see what you all wanted to talk more about. So the last group of data that I'm going to show you before I talk about the paper are practitioner beliefs. And we asked several questions related to the beliefs around treatment. The first one I'm showing you here is a statement, and they were asked, do you agree, do you strongly agree, neither agree nor disagree or strongly agree? So it's this 5-point scale. And we're grouping it here, putting all the disagrees together, the neither as a middle kind of hazy category, and then the agree or strongly agree together in green versus the red, which would be the disagree. So the first belief statement was, people in the community where I work have adequate access to an effective form of addiction treatment when they need it. We can look at these responses within each state based on the rurality of the practitioner, or we can look across states, comparing Vermont to New Hampshire. So the top bar are respondents from rural areas, and the bottom bars are respondents from non-rural areas. So first, let's look within the states. So it's clear that there are no differences between rural and non-rural practitioners and how they feel about people having adequate access to effective treatment. Second, we can look across states, and we can see that a greater proportion of New Hampshire practitioners disagreed with this statement compared to Vermont practitioners. So this is something that is interesting and we might think more about, but I think it gets at what I was mentioning earlier, that Vermont has really been a leader in some of these early efforts to improve access to treatment, and New Hampshire is adopting these same, what's called hub and spoke treatment efforts. They just have been doing that more recently, and they're trying to get that up and going. The second belief statement that we put out there for their response was, if a person came to me and confided that they were suffering from opioid addiction, I feel confident that I know where to refer them to treatment. So again, looking at these responses within each state based on rurality of the practitioner or across states, comparing Vermont to New Hampshire, first we see within states Although there's a slight visual difference between rural and non-rural responses, there are no statistically significant differences in how confident they were to know where to refer a patient for treatment. And secondly, across the states, a slightly greater proportion of New Hampshire practitioners agreed with this statement compared to Vermont practitioners. So they feel like they know where to refer patients, although that they have some limits on having adequate treatment. So there's more to learn from these different beliefs. The third statement of belief that we asked them was that medications like methadone and buprenorphine are the most effective way to treat people with opioid use disorder. So first, within each state, although, again, there's a slight visual difference between rural and non-rural responses, there are no statistically significant differences in whether they felt medications were the most effective way to treat people with opioid use disorder. And across the states, when you compare New Hampshire to Vermont, there are again no significant differences in agreement with this statement, although visually it looks like there's a lot more in New Hampshire who are neither agreeing nor disagreeing in the rural subset. So overall, it looks around 60 to 70% of the practitioners are agreeing or strongly agreeing that these medications, which are evidence-based, there's been a lot of research showing the effectiveness of these medications to treat opioid use disorders, and them being the most effective way to help patients with opioid use disorder. And the final belief statement that we put out there was medications given to treat people with opioid use disorder replace one addiction for another. And here you see more practitioners are disagreeing, and it gets a little more interesting. So within each state, the non-rural practitioners disagreed more than the rural practitioners about whether medications replaced one addiction for another. So there's still some belief out there, a sizable percentage, almost 30%, that feel, oh yeah, if you give them this other medication, you're just replacing their addiction to another drug. And then this pattern, this difference between rural and non-rural areas, and the belief around this statement is similar in Vermont and New Hampshire. So in the non-rural areas of New Hampshire, they were more of them disagreed with this statement. So I'd just like to end this section of showing you lots of data across the two states with a couple more quotes. We asked participants, what would you recommend as the single most important improvement to increase access to opioid use disorder treatment in your community? A Vermont practitioner said that continued coverage for telehealth and or transportation support is the single most important improvement. And during COVID-19, as we all know, there was this stark increase in telehealth, and actually there were some modifications to the federal treatment policy that allowed telehealth for new patients with opioid use disorder and treatment with and prescribing of medications over telehealth without having a first initial in-person visit, which during COVID was the big deal. So you could initiate and start new patients now without having that first initial visit. And in New Hampshire, they're saying access to inpatient beds. There are a number of individuals that do not want the medications, but they don't feel they have other options that are easily accessible. So they're really in New Hampshire worried and struggling with these other forms of supports, and specifically inpatient beds for patients. So I'd like to spend the last 10 minutes. Do I have that much time? I can go a little bit quicker. But we had some questions in the middle, so maybe I do have 10 minutes, and keep sending questions, it's fine. I wanted to share with you a study that we've submitted and is under review and at Preventive Medicine on the association between the comfort. Remember, I showed you how comfortable practitioners feel about treating opioid use disorder, and the barriers to treatment. So we looked at associations between these two. So I have many co-authors on this paper who I've listed here, all within the Center on Rural Addiction. Some of our clinician advisory board, our partners across Northern New England, as well as faculty and staff here at UVM. The sample for this study were primary care practitioners specifically in Vermont. So it's a subset of all of those practitioners that I showed you the data for earlier. And it's 116 primary care practitioners. And I focused on these because it's a majority of our assistance that we're providing to practitioners is within primary care and helps of increasing the amount of number of practitioners who are prescribing medications for opioid use disorder and supporting their treatment and management of their patients with other substance use disorders. So the objectives of this paper were first to examine the primary care provider perspectives on patient opioid and other substance use and their comfort treating opioid use disorder, and then also to determine these associations between their self-reported barriers to treatment and their level of comfort treating opioid use disorders. And we brought in this aspect of the rural and non-rural areas in which these practitioners worked. These data are just Vermont because the New Hampshire data are hot off the press, which I showed you today. So they're not in this publication at the moment. They'll be in other publications though. So our study sample of Vermont, just a quick breakdown. We had about 50% male and female, slightly more in rural areas than non-rural areas. And here this OAT is another way of saying the medications for opioid use disorder. It actually stands for opioid agonist treatment. So that means whether or not you're waivered to prescribe buprenorphine or not. And there was an equal split between these two. Because as I mentioned, whether you're waivered to prescribe is really going to affect what barriers you experience and as well as your comfort treating. So here's a quick box and whisker plot of their answer. This subset's response to how comfortable are you addressing or treating opioid use disorder in your patients. And so on average, they answered around a 7 in their comfort, and the scale again was from 0 to 10. And you see there's this broad variability, and some respondents were way down by 1, and there were some up by 10, but they're tightly clustered around 5 to 9. So looking at this figure, these are again the barriers to treatment identified by the Vermont primary care practitioners. And as you may recall from earlier slides, time and staffing constraints are a major barrier to treatment identified by these primary care practitioners. Also, concern around medication diversion, managing their patients and others. And then down near the bottom by the Vermont practitioners, they said stigma was not one of their barriers. So here we have the differences in the average level of comfort treating opioid use disorder based on practitioner barriers to treating. So the different colored boxes are yes, it is a barrier. So the white is yes, it is a barrier, and the green shaded boxes are those who said no, this specific one is not a barrier. And then on the y-axis is their within those subgroups of whether or not they felt there was a barrier, their mean level of comfort in treating. So here you can see that there are 3 of these associations that stand out. So the first is the barrier of lack of training or experience. There seems to be a big difference in the practitioner's level of comfort treating opioid use disorder if they say that it's not a barrier or if it is a barrier. And then also for insurance or reimbursement issues. So those who say, yes, this is a barrier, they seem to have a higher level of comfort compared to those who say, no, it's not a barrier for insurance. And finally, constraints on time and staffing. There's a difference between those who say, yes, it's a barrier in relation to their average level of comfort treating opioid use disorders. So let me tell you specifically, I've got them written out here, for the differences in the average level of comfort treating opioid use disorder based on practitioners' self-reported barriers to treating. If you asking the practitioners, you say, a practitioner who has identified lack of training or experience as a barrier, they had 1.3 points lower average comfort level treating opioid use disorder compared to other PCPs. This value is from a multiple linear regression result where we controlled for confounding effects of the gender of the practitioner, the rurality of where they worked, and whether or not they had a waiver to prescribe buprenorphine. So this goes in a direction that we understood initially when we saw this. We said, okay, if you lack training, then you're going to have a lower average comfort in providing treatment. And that makes sense. So, you increase their training, they'll be more comfortable. The other two go in the opposite direction, and I'll talk a little bit more about these. So those PCPs who identified insurance reimbursement issues as a barrier had, it's the same magnitude, it's a 1.3 point higher average comfort treating OUD compared to other PCPs. And similarly, constraints on time and staffing. So if you identified that as a barrier, you had a 1 point higher average comfort treating opioid use disorder compared to other primary care practitioners who didn't say that was a barrier. So these two barriers are interesting because they go in an opposite direction. And what we learn is that it's because you're actually providing the treatment and you're running up against these barriers. And as you provide more treatment, you have more comfort in providing the treatment, but then you experience these other barriers. You have to deal with insurance issues. You have to deal with the time and constraint on your staff and the time it takes to work with the patients in the office in comparison to other patients. So it was an interesting flip, and we talked with some of our clinicians about this, and they seem to support that conclusion that we had made. So that's the last slide I'm going to show you, is just our discussion and conclusion, which I just mentioned, is that lack of training or experience was associated with less comfort treating patients, but then other barriers like insurance issues and time constraints were associated with more comfort. So, therefore, ongoing support in clinical operations is likely a critical element in expanding primary care providers and access to OUD treatment in the settings of their offices. And I think that, we found these really interesting results in Vermont, and we've run some preliminary analyses on the New Hampshire data, which I haven't shown you, but Nate ran them, and they are showing the same three barriers are showing similar differences in terms of their comfort in treating OUD. So the sample sizes are a lot smaller in New Hampshire, but we're finding the same patterns across the two states. So we think that's really interesting. And with that, I'm going to end, and happy to answer more questions. Maybe also Nate looked up that other category and he can tell us about that.
Absolutely. Yeah. So I wrote down a few things in the chats, but this is not a quantitative, but looking through qualitatively, just at the other barriers identified for practitioners in both states and for patient-related barriers. So for practitioner-related barriers, many, if not most, of the practitioners were identifying essentially reasons within their own scope of practice. Some might say, "Oh, this is my specialty. I don't deal so much with that population. It's expanding my scope of practice if I were to work into that." But there are also other like cross-cutting barriers. Sometimes people use the other as a point of making a comment section based on the barriers, as sort of an available text box. But also, people mentioned the availability of opiates. Some people expressed, concerns over MAT, which could have been lumped into that concerns over treatment box, as well as co-occurring substance issues. And then just a general lack of provider availability for treatment, talking on the subject as a whole. For patient-related barriers, these were interesting. Co-occurring mental health issues was a very commonly mentioned factor, as well as an accompanying lack of mental health care access. And that can sometimes go along with patient readiness to undergo treatment, but there are lots of comments saying, okay, sometimes people aren't necessarily personally ready to be treated. And then something that came up a few times was a lack of stable housing. And based on that, because that is a very specific barrier, we added that as a point in our main baseline needs assessment, a specific response that would be available. So in the coming months, we'll see how people respond to that when it's out there and put in front of them.
Oh, right. I remember that discussion. Yeah, we would see things put into the other category, and then we've actually modified the survey that went out to Maine to include that as a response. So thank you so much, Nate. Other questions, thoughts? Again, reach out to the Center on Rural Addiction. Reach out to me. I'm happy to engage and talk more about what we're finding, and especially when the Maine results roll in early this summer, and then Northern New York likely end of summer, early fall. So we'll have lots more to share.
Great. Thank you, Val, so much for joining us.
I appreciate the opportunity. Thank you.
Have a great day, everybody.
Thank you.
Thanks.